know who was here. So,
Good evening, everyone. We're going to go ahead and get started. People will continue to trickle in. Thank you very much for coming out on this dark and rainy November evening. My name is Denise Figno. I'm with Development and Communications at Howard Center. This is our third in our Fall Community Education Series, which is a new project for us. We've been very excited about it. Our events have been well attended. We had 2 previous presentations. So before I introduce Julie Smith, I'd like to just go through a couple of announcements. Firstly, if anyone needs to depart early or use the restroom, we have ushers that will help you navigate through this amazing building. Thank you so much to Dealer.com for hosting us. Thank you to VCAM for videoing us. We have Elizabeth and Wendy here in the room tonight. A couple of things we want to mention that are also coming up on Monday night. We're going to be hosting Paper Tigers Movie, which you'll find a handout in your presentation packet at the Main Street Landing Performing Arts Center. That's Monday, November 16th, this coming Monday at 6:45. And that should be a really good film. So if you have time to come out, please do. We're also planning to have a spring series, and we'll be starting in March. We'll be kicking off with another presentation on autism in adults, and we're going to be partnering with Vermont Stage. They are going to be showing a play, or they'll be presenting a play called Dancing Lessons, and that has an adult character with autism. That begins on March 9th, I believe. So be looking for that. You'll be on our mailing list, and we'll send out announcements about all of this. We'll have a question and answer period right after Julie's presentation. And so without further ado, Julie Smith, a Howard Center staff person. We're so excited to have her. She's the director of our Autism Spectrum program and oversees the implementation of school, home, and community-based behavior intervention services for children with autism and families. She also provides training and coaching services in the schools and to community professionals. She's been with Howard Center for 16 years and with the Autism program for 14 years. So welcome. Thank you very much.
thank you. So let's get an idea of who is in the audience. That would be helpful for me. So how many people are family members of an individual with autism? Okay, great. Educators? Great. Community members support people that know people with autism? Awesome. All of the above. Thank you. Thanks for being here. So, understanding autism. Really, this is just a broad view of ASD, and what we'll be covering today is what is autism, the new DSM-5 diagnosis of autism spectrum disorders, potential causes, what people are saying now cause autism. We'll also talk about communication strategies, managing difficult behaviors, some effective programming, and helpful supports for people with autism and family members. So what is autism? Autism is a neurodevelopmental disorder that's characterized by challenges in social interactions, communication, and then stereotypical behaviors or repetitive behaviors in interests and activities. The prevalence of autism spectrum disorder, it's 1 in 68 children or individuals have autism. It is the fastest growing developmental disability and most common developmental disability in the US. Boys are nearly 5 times more likely than girls to have ASD. And just really those stats are enormous. 1 in 42 boys and 1 in 189 girls currently have autism. There are some data out there that says there's an increased risk among siblings as well. So the Diagnostic Statistical Manual of Mental Disorders really is used to diagnose mental and behavioral challenges. And there was a new DSM published in 2013 that changed that pervasive developmental disorder to autism spectrum disorder. And really what that means is they dropped those thresholds of autistic disorder, Asperger's syndrome, and pervasive developmental disorder, not otherwise specified, so the PDD-NOS. The rationale for the change, really there was a scientific consensus in regards to the separate disorders. They're actually a single condition with different levels of severity. So they figured that the old DSM criteria wasn't really precise enough, and autism is defined by a common set of behaviors, and therefore it should be characterized by a single name and then according to the severity. So some of the specific changes. The new criteria are more thorough and strict compared to the old criteria. The symptoms needed to meet the criteria within the area of fixated interests and repetitive behaviors. The communication and social interaction domains are combined under one titled social communication deficit. And the requirement of the delay in language is no longer necessary for a diagnosis. So to receive an ASD diagnosis, you must meet the criteria A, B, C, and D. A really is around the persistent deficits in social communication or social interactions across contexts. And in order to meet this criteria, you must have a manifestation in all three areas. So those deficits in social-emotional reciprocity, the deficits in nonverbal communication, and the deficits in developing and maintaining those relationships. For criteria B, it's around those restricted repetitive patterns of behaviors or interests or activities. And in order to meet this criteria, you have to at least have two of the following out of these four. So those stereotypical repetitive speech or motor movements, the excessive adherence to routines or ritualized patterns of behavior. So sometimes you'll hear people say, oh, my son has OCD, or my daughter is engaging in some OCD-like behaviors, and that's where you'll see those repetitive excessive adherence to routines and patterns. Highly restricted fixated interests, so that are abnormal in intensity or focus. And then the hyper or hypo reactivity to sensory input. So here you'll see maybe somebody who has a high threshold for pain. They might bump their head where we kind of have a reaction. They don't. Or maybe you'll see, your son or daughter or student cover their ears when they're in the hallway or need adaptions with headphones or whatnot when they're in the cafeteria. C is symptoms must be presented early in childhood, but may not become fully manifested until the social demands exceed those limited capacities. So really, the manifestations of the disorder vary greatly, depending on the severity of the condition, the developmental level, and the chronological age. And so that's where the symptoms together limit and impair everyday function, but there's also a severity qualifier that we look at right now. And that's either level 1, 2, or 3. And there's a handout in your folder there that describes, right from the DSM, that describes what these represent and what these mean. Any questions? Causes. There is no one cause of autism, just as there is no one type of autism. So most causes of autism appear to be the combination of an autism risk gene and an environmental factor that's influenced in early brain development. So when you look at research, the last 5 years, people have identified a number of rare genes or mutations associated with autism. And there's a small number of those that are sufficient to cause autism just by themselves. However, there are also these non-genetic or environmental stressors that researchers say increase the child's risk of autism. So some of these events happen before and after birth. There's an increased advanced parental age, both mom and dad, maternal illness during birth, difficulties during birth where there were periods of oxygen deprivation to the baby's brain. But really, these factors by themselves do not cause autism, but rather the combination of the genetic risk factor and the environmental factor increase their risk. Yes?
Are you going to want to ask, can we ask?
You absolutely can.
Maternal illness during pregnancy, what would something like that be?
Just in regards to, there's a lot of research behind, high-risk pregnancies. So where there is some discussion around, was the oxygen cut off for a certain period of time? So, and it can be anything from the high blood pressure to, smoking or, not being healthy during pregnancy, that type of stuff. So if you are high risk, they're saying like some of the high risk pregnancies tend to have some risk. Yes?
I thought I just read some new research suggesting that a risk factor also is a large age difference between the mom and the dad, and it could go either way.
Mm-hmm.
The mom being older or the dad being
Yes.
older, is that correct?
Exactly. Yes. It can either be the mom or the dad, but whether the mom, and that's where you see that age difference, it doesn't matter who it is, but the research is saying that the advanced parental age can be a risk factor for autism.
It can be one or the other.
It could be one or the other.
It says both, you mean both, either the mother or
Either the
father,
mother or the
right?
father. Sorry.
And I thought also, though, that the research had suggested that was true even with young parents in their teens, so that a large age difference of maybe a 19-year-old and a 30-year-old.
Sure.
So I don't know if I would classify that as advanced parental age.
Right. Yeah. I have not read that. Any other questions? Yes.
Just wondered if you could comment on Fragile X. My understanding is that is a known cause of autism, and you can test for that before you even get pregnant to see if you're a carrier.
Yes, and the mother is always that carrier. And so in the DSM, it would be ASD. It would be autism associated with Fragile X syndrome. So some communication strategies that are effective with individuals with autism. It's helpful to really get to know the individual, get on their level. So building a rapport, making sure you know their interests, and literally getting on their level. Whether you're bending down, playing with them, don't be afraid to be on the floor with them, really communicate with them. Establishing attention, and this doesn't necessarily mean getting them to look at you. It means establishing their attention, making sure you know when they're paying attention. Because if you're asking them to do something or you're communicating a need and you don't have their attention, they're not going to comply or they're not going to be engaged with you. It's important to prepare the individual for what you're going to communicate. So this is just a matter of thinking about if your child is having a hard time transitioning from dinner to the bedtime routine, really setting that up so that they know what is coming next. And that might be through the use of a visual or just one term or a use of a visual timer, so to speak. But what needs to be put in place in order to prepare the individual for what you're going to communicate is very helpful. The use of gestures and body language make sure you use them meaningfully, purposefully. You see me, I'm like this, I'm a hand talker, kind of all over the place. So sometimes that can be really distracting to somebody with autism. So use them sparingly. If I want them to go somewhere and I point, make sure I keep my point there for a second so that they can look, respond, and do what I'm asking them to do. In regards to the visual supports that you use to support communication, you have to make sure that it meets the needs of the individual. So are they pictures? Are they actually photographs of that individual doing the items? Are they text? Is the person that you are supporting or live with, can they read? So maybe you're just writing them please go do this, or you're writing them a visual schedule. So support your communication visually. Goes a long way. Speak slowly, clearly. When we're using those vocal verbalizations, we want to make sure to use concise language and match those students' needs. So some of the students I work with, I can talk just like I am talking with you right now and have full conversations and they can follow. Other students, I might have to pare it way down, whether I'm saying, please sit, or just sit, right? We have to be mindful around what they can process, their processing delay. Some students that I've worked with have a 7-second process delay. And for us that don't have autism, that can feel like a really long time, right? But it's not to them. And so being mindful around building rapport with that individual, getting to know that individual, meeting them where they're at, and then tailoring your communication style to best communicate with them. Prompt as needed. So it might be that, I want somebody to come sit next to me. I might just tap the seat next to me, or I might just point, or I might just show them, come sit, a picture of something that makes them know that they can come sit. So around the guiding and the prompting, people need support. It's important to know what support that individual child needs, but it's all different. The avoiding socially challenging language and figures of speech, this is really important. The majority of the individuals that have autism that I work with are literal thinkers. So, I worked with a student who I was out getting lunch and their father worked there. And so when I came back, I said, hey buddy, I ran into dad today and he was mortified. He asked me if he was okay. He thought he was in the hospital. Did I kill him? And I said, oh, no. I mean, I saw your dad today. He says hi. Can't wait to see you when he gets home. Or, we were this summer at a swimming outing, and a bunch of us were swimming, and, staff member had hair up on the top of their head in a bun. And, of course, her hair had fallen down, and she said, oh, my hair fell out. And the kid was like looking around trying to figure out how to pick up the hair to give it back to her. So really being mindful around the figures of speech and the irony that we use, even when talking to other people, so talking to our spouses or talking to other adults in the environment, make sure that you are using the social language appropriately. Yes?
I work with some young men who are high functioning, but a lot of them are on the spectrum. And a lot of what we do in the house as the workers, we throw around a lot of sarcasm. And I kind of feel like, yes, it's good like when you're in stressful moments to keep it direct.
Mm-hmm.
But part of real life, like your whole goal is to get out there and live independently. You kind of have to, I think, play around with these things so they realize like ways to adapt. So I'm curious like where the threshold of learning this stuff, like where it ends.
Sure.
Because I was doing an art project with this kid, and my other coworker goes, "Oh, that's dope," and he goes, "No, it's not."
Right.
And he thought he was saying it was drugs. And he goes, "That's why all the kids in my college class, I thought they were all admitted drugs."
There you go. That's a great example. Yeah.
Figure of speech, like, it needs schools because they're learning.
Mm-hmm.
So my question is like, how much can you go there? Like, what's the ability to learn sarcasm and to kind of open the mind to it? Like, where does it end?
I think it all depends on the learner.
Yeah.
I think it's really important to teach that type of stuff. And so it's around, when do we start doing that? Kind of observing your environment, so to speak. Are there first graders using that type of speech? Probably not, right? So when do we say, okay, we start teaching it at this level? It's specific to the individual and where they're at. But I absolutely do think that we have to teach it, right? It's important. But when we're communicating that type of stuff, be prepared when it sounds like you work with some young men who are higher functioning, so that you can have this type of interaction or natural teaching opportunity when these arise. In regards to communication, there are some perseverations that individuals with autism can exhibit. So some of these are vocal in nature, so they're repeating the same thing over and over again, or they're asking you to repeat the same thing over and over again, or an action over and over again. And I just wanted to point this out that, I want people to be patient with these perseverations. Sometimes it's easy for us to attend to that or say, nope, we're done with that, we're not talking about that anymore. And so just be mindful and creative around how we can attend to those behaviors in a positive way. So keeping a neutral tone of voice, body language, that's very helpful. Maybe with individuals who are readers or who can kind of have a text prompt, you just ask him maybe to write down the response and you're responding. And so if he's still perseverating, you can redirect with the visual cue. I think the other thing is to try to redirect to a different topic. You know your children the best, and so whether it's your actual child or the person that you support in the community, you know their interests. So if there are, something happens, they're perseverating on it, you know how to redirect them with a more appropriate activity, or it gets their mind off of it. It's important when sometimes individuals with autism engage in perseverations for that automatic reinforcement. Makes them feel good, or it might calm them down. So you might see these behaviors happen when there's high stress or something stressing them out. So be mindful of that. How you respond can then calm them down. If you point it out, you've already said that, your tone of voice is different, it's only going to stress them out more. So be mindful of that. Okay. So managing difficult behaviors. I'm not going to go into this hugely, but what I want to point out is that communication serves a function. All communication behavior is a form of communication, and there is a function. So the most common functions that we see are to gain attention, right? So they're behaving a certain way to get our attention. Or there's a certain behavior that they emit to gain access to an object or an activity or whatever it may be. They might behave in a way to avoid a demand situation or to escape a situation that causes them fear. I think of, an individual that we support who cannot be in the cafeteria at lunchtime. It is too noisy. So some of the behaviors that we see is bolting, right? Get me out of there. Do not want to be there, to escape the loud noise. And then automatic. Some of those automatic behaviors we can't see, it's internal. So you or we can't observe that. But I think what I wanted to point out is that all behavior, you and I, individuals with autism, anybody, it is all a form of communication, and there's some type of function behind it. So, you have a child who's engaging in difficult behavior. It's important to reduce the stimulation, right? Something in the environment, whether it's the lighting, whether it's your tone of voice, whether it is the laundry all over the living room, some type of stimulation, right, is supporting this person in engaging in a difficult behavior. So reducing that stimulation will help them. Do not attempt to verbally de-escalate the child. More of this will only increase their stress level, right? And how much are they actually hearing anyway? So it's your body language, it's your tone of voice, it's the way that you're moving towards them, it's the visual supports that you're using, but it's not the language that you're using or the vocal output that you're exhibiting. Using visuals, and if you do have to use directives, using verbal, like short, sweet directives to communicate what you need. So it's sit down or come here, right? Not, I would like you to calm down and sit down over here next to me so we could talk about this. So making sure that it's short and concise. But the visuals go a long way. So whether it is showing them a picture of what's expected of them. So whether it's a picture of a chair for sitting, and then what's coming after that. Whether it's they're getting their dinner or they're getting their favorite TV show or whatever. Give them a visual, what's expected. Do not process in the moment. Again, I mean, these individuals, if they're engaging in difficult behavior, they don't yet have those coping strategies to settle themselves down and then process or learn about coping strategies in the moment when they're stressed, right? So wait until they are at a place where you can do the teaching. It's not when they're engaging in the difficult behaviors. Allow sufficient wait time between the directions and the expected response. Again, some of these individuals have a long processing time. So waiting 7 seconds is appropriate for that individual. And then the reinforcement. Once the child is able to comply, is able to start to listen to what you are saying or answer or follow through with the demands that you're placing on them, make sure you provide some type of motivation. So, and that could be as simple, natural reinforcement, right? You sit down at the dinner table, he gets to have his dinner. If he puts on his PJs, he gets to have story with mom, right? So thinking about those reinforcing activities really goes a long way. So there's some type of motivation to engage in what you're asking them to do. So important supports for individuals with ASD and thinking about difficult behaviors, information presented in multiple formats. So knowing that your child may be able to listen to your directions if you say, come sit, but something is happening where they're not able to comply. Have a backup, right? Okay, here's my visual, let's try this. So presenting it in multiple formats will support. Consistency, predictability really does help these guys out. So if they know that they come home from school and they do X, Y, and Z, and there's some type of support in there that shows them that that's what's happening, the chances of them having a successful afternoon at home are higher than coming in and not knowing what to expect. The feedback about inappropriate behavior, it's important, right? But it's not in a punitive way. And you can do it in a way that a child is complying with you, and you just kind of give them a squeeze. Nice job, buddy, sitting with me. I love the way you're talking, right? You're giving them feedback about appropriate behavior and then being mindful around how you deliver the inappropriate behavior. And you do that around teaching, so not when they're engaging in those maladaptive behaviors. So it might be a couple hours passes where you present a social story around expected behaviors, or you present a video model around what you want to practice instead of that inappropriate behavior.
Do you revisit and talk about the inappropriate behavior when they're older? I'm talking about your students that are certainly higher functioning.
I think that it depends on the individual and what that person needs. So if you're dealing with a high schooler that is really mainstreamed and understands what is expected and what is not expected, yes, you have a teachable moment around that. And you rehearse and practice. So when they're not before the situation is about to arise, you practice. Okay, we're going into the restaurant. It's 5:30. It's going to be noisy. It's going to be loud. What are we going to do? And you talk about it in the car before you walk into the restaurant, right?
I was mostly thinking of revisiting when they were really out of control.
Like processing
And
types?
processing it after, like, that really scared me. You know, you go through the whole, and I have just been in many situations where parents and teachers did not want to do that.
Right.
And I guess I'm just putting it out there. What is your thought on
What is acceptable? I think it goes back to the individual, right? It's so different.
It is.
Wouldn't it be so easy if we said, okay, this person is a female and they're 13 years old and they have this much language. So let's open the manual to section G and start there and go to Z. It doesn't exist.
No, it doesn't.
Because ASD is such a spectrum and these individuals are so special and unique and have their individual needs, just like you and I, right? And so I think it depends on that individual. So if there was a situation which really scared you and they can process that after the moment, I still am a true believer after the moment, that you can process and do some teaching around that. And they can understand what that means, right? Have that empathy, understand like I just scared somebody,
And they can
right?
understand, but sometimes you think they are understanding it.
Correct.
You know, it is such a wide tip.
Yeah.
I'm just very interested in that, and
Yeah.
probably always will be, and it will be in the individual. So.
And in a few slides, I'm going to be talking about some of the evidence-based practice, and one of them is that cognitive behavioral support. That's where you get into some of that. So some individuals really can participate in that type of therapy and have that interaction and that teachable moment, for sure. You're welcome. Any other questions? Yes.
We've got to use the mic.
Oh, well, I'll just talk loud. One of the things that I've noticed is conditionals, if then, maybe might, vague time periods, in terms of processing, doesn't go a long way. It
Yeah.
actually messes things up. So-
Right, those concepts that aren't black and white, right? Like, what does that mean to me if I say,
Yeah, the sort of
in a few
mulling
minutes.
over of things. I think when you come into it, you have to have like maybe 2 choices only, or 1.5 choices, and then not get all conditional about it. You know, like you were saying, keep it minimal and
concise
be
first,
efficient.
then
Yeah.
we're going to do this, and then we're going to do this, right? And have the supports in place for them to follow through with that. Can you give me an example of what you're thinking about? Like when you said give them a choice or a choice and a half, what do you mean by that?
Choice and a half is kind of like, you know, the half choice is probably not going to be a very good one because
Okay.
you want them to choose the one that you want. I mean, you know, I'm talking about efficiency because this can go on for hours.
Sure.
And, you know, in terms of processing, maybe maybe if you talk about it 2 hours later or tomorrow, it's just gonna bring it all up again, the tantrum's gonna happen again.
Right, and that's why it's individual, right? For that student or that individual, absolutely. For maybe the one that you're talking about, it could be a completely different learning experience. It really depends on who the person is.
But yeah, I've really found that if you're not prepared ahead of time and if you're using vague language, like, maybe you might wanna,
No, because probably they don't want to. So, or when you ask them, can you come sit with me?
maybe
No.
might or, vague,
Mm-hmm.
uncolorful, clear language.
Right.
just Doesn't work.
Anybody else? So when we are taking communication and we're taking behaviors, there are some elements of programs that we can implement at school, at home, in the community. It's important for them to be structured, to know what you're going to do. Your point exactly. If you're going to give the child choices, make sure that they're choices that they're okay to pick, right? Skill-oriented. What are you actually working on? Are they those behaviors like daily living, where you're doing toileting, or you're doing eating programs, or what are they doing? There has to be some type of skill set behind it. Again, tailored for that individual, making sure that this is what I'm doing with this child, that it's working. It's not going to work for this child, so I have to make adaptations and tailor it to the individual. And like I said previously, there isn't a guide where we can just open up and say, start here and end here and you're good. No, there's multiple ways that we have to tweak and adapt, and what we think is really going to be great with this, individual we put in place, and it's not so good. So we have to tweak and adapt again. And so it's really important to tailor it to the individual. I'm big on motivational systems. When you think of you and yourself and just your everyday world, right? There are things that you're going to avoid because you don't want to deal with that. And there are going to be things that you're like, yes, I can't wait to do X, Y, and Z because you're reinforced by it. There's some type of motivation. You like doing that. You've been reinforced before. So having some type of motivational systems in place will support the individual in whatever whatever skill you're teaching, communication, behavior, academic, any of that stuff. Predictable, structured, organized. These are things that are really important for these individuals. There are times that I'll walk in to a school setting or a classroom, and at circle time behind the teacher where the student's supposed to be sitting, there's artwork and there's calendar and there's the weather and it's whoa, it's like overstimulating, right? And so how is this person supposed to sit down and listen to you when there's like so many other things going on behind you? And so being organized and being predictable and structured will help out when you're implementing programs. Intensive. This takes a lot of practice. So being consistent and having those supports be intensive is huge. So if you're doing a morning routine, you do it the same time every single day for them to learn those. You're doing it, and then you're doing it. It's consistent across the board. Or if you're working on the toileting, how many people have toilet trained their kids, right? You do it the same way every time, so they practice this positive behavior, so they're able to engage in that behavior. Or same thing with communication, right? If we're teaching functional communication, and you're going to grant them to say, I need a break, I want to go to my room, well then let's practice them saying those things and not also letting them go to the room when they just get up and leave. So consistent and intensive and a lot of practice. the generalization is huge. So to be on the same page with the school and with the family really supports effective programming. So the way that you are doing toilet training at school, the goal is for them to do it the same way at home, right? Or vice versa. Or you're communicating with the school team around what's being served for lunch. Okay, they might not eat that. Let's figure out how to expand their eating repertoire. How do we do that appropriately across settings? Similar with communication. You know, we have a lot of kids using augmentative communication devices from an iPad. So they'll have pictures where they're pro loquo to go, where they're having pushing pictures, and then there's an output that says, I want to break, or communicating their needs. That needs to be brought home too, so that they can communicate their needs at home as well. Any questions about that? The specific strategies for communication and sensory deficits. We have individuals who have sensory needs, and it's really important to be mindful of that. So I gave the example of a student wearing headphones or noise cancellation headphones in the cafeteria because it's really echoey, right? It's really loud. That's just an element that can support effective programming, knowing what those individuals need so that you can actually implement it will be effective. Or what type of things do they need in the car before you go into the restaurant? Is it a social story around these are the expectations when we get in there? So they're prepared for when they walk in the restaurant to have that meal. And then what happens if it doesn't work out? When you go in and the restaurant says, oh, it's going to be a 35-minute wait. Okay, well, that's not going to work out. What's going to be my plan to get out of here without a difficult behavior? So again, being specific and having strategies will go a long way. Yes?
How do you figure out what the sensory deficits are? Like if you say include strategies for sensory deficits, well, how do you know if they can't tell you?
Mm-hmm. It's through observation. It's through communication between the people that know them best. You know, asking mom and dad, when you see this, does this happen? Or really observing, taking data, figuring out, okay, so, you know, if I'm thinking of that student that we had the largest issue getting into the art room. We couldn't figure it out. And so we do a lot of different supports to get them into the art room. We go early so that there's not a lot of people in the hallway at that time. Nope, that didn't work. Okay. We're going to have a motivational system so that when he steps foot in the door, he's going to have something fun that he likes right there. Well, that didn't work either. What's happening then? Then we take in the whole environment. You know, it ended up being that there was this huge art dragon project that they had done, and it was really cool, but he was scared to death of it. It took us a while to figure it out, but the minute we took it down, he was able to go in. So again, it's around process of elimination sometimes and really gathering everybody's input around what that sensory deficit is. It is. I mean, I've been at home visits and quick kid, climb up on the counter to get something on the top of the fridge, slip, hit their chin on the way down on the counter. And I'm like, oh, there's definitely blood everywhere. It's got to be. No, there wasn't any blood, but he wasn't making a peep. So that sensory deficit we have to take into consideration too, right? Because of the safety issue. So if he doesn't feel pain the way that maybe I feel pain, how do we make sure those safety elements are in place, right? Because we don't engage in things that cause us pain. So when I close my car door, I know to move my hand. So my hand doesn't get caught because I don't want to feel that pain. So if he doesn't feel that pain, how do I teach him that? So again, it's around taking those sensory deficits into consideration.
What are the theories around
Yeah.
I think the mic is hooked up to the cameras.
Here we go.
I couldn't talk loud. I can talk loud. No, good.
Okay.
So what is the theory around desensitizing children? Say I work with young children, sometimes age 3, who have, sensory overload issues in various ways. and of course it depends on the individual child, but and how much they can take before they get anxious. But ultimately, for some of them, we're trying to move them out into the world.
Sure.
So are there theories around that? Or again, is it just an individual child?
Oh yeah, it is individual, but there are desensitization programs that you can implement in a very systematic way to meet that child's needs so that they can get over that defensive. Now, you might have an individual who needs the noise cancellation, but we can move from, the headphones that are here to like itty bitty earplugs that nobody can see. That's more socially appropriate. And there's a desensitization program that we can implement for that. Individual to that student, but in a systematic way across the board. And you manipulate the environment to practice it and to get a little bit ahead each and every time. So I have a student that we've been with since he was little and so scared of those fire trucks. He lived in Burlington, all over the place, multiple times a night, right? And so we would have to do creative programming around that. Now he can walk right past the fire department to go to the movie theater and not freak out anymore. But it took him a while, right? He was scared. So how do we do that? Very systematically. Anybody else? All right. So the National Standard Project. This is developed from the National Autism Center in Massachusetts. And when it was developed, actually, they're on their second phase. But the first phase was launched in 2005, and a bunch of scientists went and looked at a variety of different articles so that they're able to come up with the most comprehensive analysis of evidence-based practices to support children or individuals with autism. And so the first phase came out in 2009, and then the second phase they launched in 2011 to really look at the studies that have come up from 2009 until now, and they launched that in 2015. And this is the website around just evidence-based practices and effective programs that we can implement with individuals with autism that are proven to work. So they came up with 14 of them. And if you go on their website, you can download the whole project. And it gives descriptions of each one of these interventions. Not only do they give descriptions, but then they'll give you an example of actually how you implement it. And so some of these are packages. The behavior interventions, that's packages. They're around reinforcement procedures, antecedents type strategies around like what happens before behavior. How do I control the environment? So it's more of a package with a variety of different treatment approaches within. Cognitive behavior intervention package, that's another one. The comprehensive behavioral treatment, that's more of the ABA. You'll see in there. Language training, again, that's more of a package as well, whether that's the use of visual supports or, Proloquo or whatnot. Articulation, that's in there as well, how you teach articulation to somebody with autism. So these are 14 established evidence-based interventions that from years of analysis, there's enough research to provide certainty that these are evidence-based interventions. They are also 18 emerging, what they call emerging interventions. So there's still research being done, there are still people running studies, but they're not quite at established yet. There needs to be more data. And then there is 13 unestablished interventions, and that is just around here are these interventions that don't have a lot of research to back it, and they need more, basically. But there's maybe like one or two articles that say that it's effective. And again, I think that it's a great tool. It goes through, it has flowcharts around how they decided this was an effective evidence-based intervention. They do a thorough job around identifying really what it means to do this intervention, and then give you kind of scenario of what that looks like. So I would encourage you guys to go on that website and look at it. It's quite comprehensive. Any questions about these? It is, yep, you can download it, it's free. You can also see, they have the phase 1 in there too. So you can see, because some of these interventions back in 2009 were emerging. They weren't quite proven, or they didn't have quite the studies that they wanted to have before they put it into established. So some of these were emerging, and now they're established. And so the 18 ones that are emerging now, you may have heard about, or you may think, oh, this is really interesting, and you can get a research article about that, but they're not quite established yet. And they do a great job citing research articles, too, that you can reflect upon to see how other people have used that. They also do like an age range, right? And so these interventions are really comment on the young ones up until 22. And then they do a little blurb of like what type of interventions are there research about for individuals that are older than 22. It's really a comprehensive overview of all the interventions and then what it took to get here.
Do you use all of them in your program?
Almost all of them, yes. So, our program has around 40 children in it, and they range from 2 to 22. And so depending on that individual, we will pull from these. Absolutely. Yes.
What's pivotal response training?
PRT is more of those teaching the pivotal response supports. So you'll see a lot of the self-management piece. You'll see a lot of this in the classroom where the peers are involved in. So somebody will come in and they might sit down at their table and pull out their notebook, and their peer is like, that's pretty cool. They're doing the same thing. It's those pivotal behaviors that we see in everyday living. It could be for a home. It could be teaching them. You could use it in teaching them how to make a meal, right? What are those pivotal response? So it's like plate, fork, bread, whatever it may be. Any other questions? No? Okay. Here are some local support resources that you can find either on the internet, the Vermont Family Network. They have lots of information, some around advocacy, community resources, special education, ethical considerations, law. So really, the Vermont Family Network website is a great resource to have. You can see upcoming trainings that are happening in the community. If you need somebody to come to an IEP meeting with you for an advocate, they're great people to contact. And then part of Autism Speaks website does have a Vermont Parent Information Center as well. And this is around VPIC, so it's a statewide network to support families, children with special needs. Yes.
Hello, I am with Vermont Family Network, and actually VPIC is no more. It became part of Vermont Family Network. That is our number there, 876-5315.
Oh.
So I'd like to welcome any parents or professionals to give us a call. We're parents ourselves of kids with disabilities or special needs, and more than happy to talk to anybody about anything that they're
Thank you
interested
for that
in.
clarification.
Couple of
That's
other
great.
resources people might want to know about. Well, first of all, I brought a bunch of our stuff. It's out on the table. Help yourself to anything. If you don't find what you're looking for, give me your email and what you're looking for, and I can send you a follow-up email. But a couple other things people might want to be aware of. There's a yearly Autism Summer Institute. It's, I think, in June, I believe. It's through UVM, and parents can go one day for free. So something to be on the lookout for. There are autism support groups in the area for families, for parents, and we are starting, with the help of parents who have stepped forward, a social group for 20-somethings who are on the spectrum, but they don't have a lot of social connections. So if you have an older adult child and you might be interested in that, you could let us know. I believe there's an autism conference this Saturday in Montpelier through a group called Aware. So if you're interested in that, I could look it up and send you the information. There's an annual Autism Awareness Day at the State House every year, so depending if you want to get connected with that. And the other thing is that we can match you with another parent. So if you're either far enough along your journey that you'd like to help another parent, you can let us know that. Or if you're looking to get matched with another family, we'd be more than happy to do that too. Sometimes it's helpful to talk to somebody who's a little bit further down the road. So.
Is the social skills group that you're trying to get for those adults, is it both female and male?
Yeah, and it's not a social skills group. It's really just
a social group.
It's a social group
Okay.
for the parents are getting involved just at the beginning to kind of help move it along, but then it's up to the young people to decide what they want to do, how frequently they want to meet. So we try to foster things like that when parents kind of identify a need and young people identify a need. So, yeah, thank you.
Thank you.
Hi, I'm just going to share a couple of thoughts that I have. I'm a grandmother to an 11-year-old grandson who has autism. And a couple of things that I want to share with you is that when he was about 3 years old, we put him on a gluten-free diet. His behavior was very difficult. And once we put him on a gluten-free diet, it really stabilized a lot of the behavioral stimming stuff. And he's been on a gluten-free diet now for most of his life. And they say that the cells of the gut are like the cells of the brain, and it really does affect their ability. The other is that for 7 years, he was doing a lot of these different methods. And we went and saw the movie Wretches and Jabbers with Larry Bissonette, and Pascal Chang, who works for Howard, is one of the internationally known people in facilitated communication. And we asked him to come down to our house to meet with Rowan, who was nonverbal and had never spoken. And Pascal came down and asked if he could point, and we said, well, we weren't quite sure. But when Pascal came down, he took Rowan's wrist, and Rowan typed, "Do you work with children who do not speak?" And from that point on, that moment, for 7 years, he did not speak. And I'd go into the school, and you'd hear him screaming in the room, and you'd go and he'd be pointing to things like truck, red, blue, simple words. And once he started doing facilitated communication, he started writing poetry. You could say what hurts, he would tell you what hurts. He'd have communication. And it's opened up this extraordinary, now he's 11, so it's been for the last 3-4 years. And it's opened up this incredible world of his mathematics skills, his reading skills, his spelling skills, his reading comprehension, and his writing skills in poetry. And it's completely transformed him as a human being, because now he can speak. And sometimes the words that we use in autism are like difficult, abnormal, limited, impaired, lower functioning, inappropriate, maladaptive, deficits, reduced, and restricted. And I think there are other words that we need to use too, like courage, connected to the natural world, reading the energy of people and animals like none of us can do, psychic connectivity, gentleness, patience, the ability to appreciate us for who we are, and some of those real positive things that we see in these really remarkable children. So I just wanted to share that story with you.
Thank you so much.
Yep.
Anybody else?
Thanks. I have two different questions going back to early on when you were talking about the change with the DSM-5 and the change in the different criteria for establishing an autism spectrum diagnosis, and that they're more strict at this point in terms of meeting the criteria. And so my first question is, do you have a sense of how many people used to actually qualify for an autism diagnosis who no longer qualify for an autism diagnosis based on the change from the DSM-4 to 5, because that can impact people's ability to access services. And then the second question is what the frequency is that you see multiple diagnoses in kids who, or adults who have autism, and if there are certain diagnoses that tend to appear most frequently along with the autism in individuals.
So the first one, if you have a diagnosis, autistic disorder, PDD-NOS, Asperger's, you don't lose that. You fall into the ASD diagnosis. And autism is a lifelong diagnosis, right? And so it's not, unless you don't meet the criteria anymore, you're not going to lose it. And I don't see a lot of people lose their ASD diagnosis or prior to the 13, like, you know.
Or the ability of people who didn't necessarily have a diagnosis.
Oh, okay.
And now when they go to perhaps get a diagnosis, I mean, have there been any estimates about, because
what that would be?
Right before DSM-5 came out, there was an estimate that as many as 30% of individuals who previously qualified for a diagnosis would no longer qualify for a diagnosis under DSM-5.
Right.
And I'm wondering whether that has actually played out and if that number is realistic or not, or if that was just alarmist.
I think it was an alarmist, right? I don't know that percentage. But what I've seen is there's a social pragmatic communication deficit as well, that kids used to maybe be diagnosed at 2 or 3 with a PDD-NOS because of that social pragmatic piece, and now that's another disorder. It's not a diagnosis that falls under ASD. So they might be diagnosed with a social pragmatic communication disorder versus
Does that diagnosis
ASD.
land under one of the categories for education, that social communication? One of the 14 categories is, or what has been 14 categories for IEPs, is that social pragmatic one that you're talking about would qualify as one of those categories?
Yes.
Okay.
Is it? Right.
Yep. Yep.
Which they typically do. Right. And then your second question.
About multiple diagnoses and which ones are most frequent.
Sure. That's really hard, right? Because some of the behaviors in which we see, they overlap, or they're manifestations. So when you think of OCD-like behaviors, right? How do you know it's not a symptom of autism versus true OCD behavior? And how do you target that? Or how do you differentiate that? And so some of the students that I work with, I definitely see the co-occurring. So I'll see ADHD, I'll see OCD. You'll see some of those co-occurring disorders. Others, they don't meet the criteria for a strict OCD diagnosis and ASD. It's depending on that individual. The way that they treat it, I do work with individuals who have ASD that are not diagnosed with OCD, but they're still working with medication to support that manifestation. So some of it is really gray. Some of it is hard to kind of section out, so to speak, right? Because ASD is a spectrum with multiple manifestations of a variety of different behaviors. And so how do you, it's hard to dissect that or pull that out. But two common ones that I do see are the ADHD and the OCD. Go ahead, Ann.
Hi, thank you. I work with adults, and often the biggest co-occurring thing we will see at the developmental services side is depression and anxiety, because these young people realize they're going to have this lifelong challenge. And that is seen by a psychiatrist and a therapist to work on that. Sometimes also when they're older, they could get OCD, they could get a number of different things, just like anybody else, a similar
Right.
percentage. But the anxiety and depression, because they want to be socially involved, they want to have partners and friends, and it's very lonely, and, you know, it's
Yeah.
just tough.
And you may see that more in adulthood than I do in children.
I was just going to mention a book that I found. I think it's new. Neurotribes is the name of it. You can get to the library. It's a history of autism, and the major theme is that it's not a disease; it's a difference, and it walks through the whole history of Hans Asperger. It's really fascinating. I haven't read the whole book yet, but
This is a little bit beyond the scope of the presentation tonight, but it did strike me that there were two facts that you might want to see a little more highlighted in the in the presentation that we have for Vermont law enforcement. A few years back, there was a mental health and law enforcement task force which developed some real training materials for the Vermont Police Academy. And two facts that I don't think are in there as clearly as you might would be the incidents, like 1 in 42 boys
Right.
that they come across might have this syndrome. I don't think there's any real awareness of how prevalent that is. And the second one, that it's in there, but not as clearly as you said tonight, that it takes some of these people much longer to process a direct command. And so you only have to watch police shows on TV. They're screaming at somebody and they've got like 2 seconds to do whatever the heck it is they're supposed to do. So, yes.
Right.
Yes. So police come at this, I learned in working on this, from a whole different perspective. And so I would just urge you to talk to them. I cannot remember her last name. Cynthia, somebody was in charge of the training. She's a really good person to work with at the Vermont Police Academy. But maybe they could just update their materials by inserting even just those two facts and highlighting them with a little story in the training, I think might be prudent.
Thank you.
Dana?
Hi there. I keep reading that there is an increased incidence of autism, and you were speaking earlier to the history of autism, and I'm wondering if that's really an increase of incidence, or are we describing a phenomenon that's been around forever? And could you speak to that, please?
I think there are more tools. People are more aware. So the screening processes at pediatric, when you go in for your well visits, they're different nowadays. People can detect it quicker, and there's more of an awareness around what that is. And I think that's why the DSM changed a bit too. The DSM is a living document that changes, and you collect more data and you collect more input and information, and you're able to learn about these things in a different way. So I think it's around awareness and education, and looking at what am I looking for at the 12-month, right? Am I looking at 6-month? Those screening processes are different too. They're more current and updated. People are looking for it more.
I do think in the mid-90s they expanded the criteria too, which found, I think, the numbers starting to climb because of the increased criteria. But I was at a workshop, training conference once with a speaker from Harvard that had done research, and this is, at this point, maybe a decade old, but he had a fascinating graph that showed as the incidence of ASD climbed, Simultaneously, the numbers of diagnoses of, at the time it was mental retardation, declined. So he had it superposed on the same graph that was showing MR going down as ASD was going up. So he was seeing the correlation with the more specific ASD diagnosis and less general classification of mental retardation. So.
One of the things that I think we need to focus on when I was coming and I saw that it was for teens is the whole hormonal issue that happens. Because I've talked to a lot of parents who have said that once a child starts going through puberty, that things change a bit. And having the tools to sort of deal with that in a child on the spectrum, I think it's an area that a lot of us don't understand, and that's done a lot of research for many years on this issue, and this is one area where I'm kind of like, oh my heavens, what's going to happen?
And we do a training on puberty, but that's
that's
coming up, I think, in the spring.
perfect. Thank you so much.
Anything else? Any other questions, comments? Yes.
Walk through an example of how you support a student in school.
Like how I support a student in school?
You have a Howard Center goes and does what?
Sure. Yeah. So if Howard Center is supporting a student at school, we typically have 2 autism interventionists that are with that child. So one in the morning and one in the afternoon. There's an autism specialist who is a board-certified behavior analyst who kind of oversees the behavioral programming and collaborates with the school team around academic programming to develop this comprehensive plan. And so we're not only supporting in the school, get to know the ins and outs of this individual and this child, but we're also working with the family too to bridge that gap so that the services and skills are generalized in the home and that we can offer some support in the home as well.
So I recently read a theory on what's happening in the brain, and I'd love to have your take on what's happening when a child starts to lose skills at around 18 months. Before 2 years, often they're speaking and then they stop speaking. What's happening, in your opinion, brain-wise, there with autism?
That's a tricky one, right? That's why they're still researching it, because they don't understand that phenomenon. I think it's around that delay. It's the developmental delay. So nobody really knows. I don't know. I think that there's that genetic component that we're still trying to identify, the breakdown in the genetic component. What does that mean around the genes in the brain and the firings of, I've been talking full sentences and then at 18 months I stop and I'm playing in the corner by myself. I don't know. I really don't know. Were you going to say something, Martha?
I'm sorry? I was just going to say, I heard Dr. Contampasa speak and answer that question. He said he doesn't think the theory of regression is not considered, valid. He said there are probably missed signs along the way. They think it's more that than, boom, there's this huge regression that happens. That was his answer to that question. He's a local doctor who specializes in autism.
But people haven't figured it out.
They don't know.
There are people that say, my son has been talking, and they do see that. Like, my daughter has been able to say mommy and dada, and they're no longer able to do that. And there's research that says, well, there's other signs leading up to that, but there are people that do report that regression. And there's no knowing about like that brain development, where that disconnect is and why they stop speaking or saying those words.
I read something I thought sounded logical, having to do with pruning of the synapses.
The firing.
Yeah, which makes sense, because if you have this overabundance of synapses, it accounts for the hyper, sensitivity and all these other things. So I don't know. I kind of.
Something like the brain is starting to prune. Maybe potentially a child with autism, the brain isn't
Right. But what they haven't figured out is that's not firing anymore, and why. So where's the disconnect leading up to it was firing the synapse and it's no longer?
No, it's too many.
Oh, too many firing.
Right.
But they can't prune it, they haven't pruned out to be able to focus because everything is coming at them at once.
It's kind of that over.
And then does their language regress because there's just too much happening? I'm not sure, it's just a theory.
And maybe also why they're, some have an ability for, music that other people don't, and because they have this, extra lines of communication or something.
Mm-hmm. Anybody else? Thank you so much.
Thank you. Thanks very much for coming, everyone. If folks could complete the feedback form, that would help us drive safely home.